My name is Angela Laurie Jones. I'm a registered nurse and I'm a senior consultant with bdna. Today we are in conversation about World Sepsis Day, which is on the 13th of September. And we're with Dr. David Farlow from Microbio, Chief Medical Officer, and Dr. Paul Lane, who is with bdna as Chief Medical Advisor.
I think World Sepsis Day is important because not many people know about sepsis, and so it's a day that we can raise the profile of sepsis. Sepsis is a global health emergency. It impacts many people, many families, and I think the other really important thing about World Sepsis Day is the opportunity for various groups to come together, our patients, consumers, families, as well as clinicians, public health leaders, to really try and work together to develop programs to improve outcomes for sepsis.
That's a good answer. And over to you, David. What are your thoughts about why World Sepsis Day is so important?
I think number one is most people don't know what it is, and from a clinician perspective, it's the patients are the ones, the community, the ones that need to have an awareness. More people die from sepsis than they do of cancer and traffic accidents. You don't see the front page news around that. And so I think Paul's really summed it up. It's increasing awareness of it as a major world health issue.
Yep, it sounds like it, and I mean in particular too, because it doesn't just catch older folk, does it? It's something that can catch anyone.
I think that's one of the myths, isn't it, that only older people or people with coexisting disease get sepsis, but indeed you can be fit and healthy one moment and then really struggling with severe sepsis the next. So it is really important that people realise that anybody can get sepsis.
So that leads me to question two. So what is sepsis? What's the definition of that, Paul?
The sepsis, the definition for sepsis has evolved, but really for everybody out there, sepsis is when you get an infection and your body's response to that infection is the word that the textbooks like to use is dysregulated. But indeed the way the body responds to the infection means that some of the body's vital organs start shutting down. And obviously then that's a critical development for the patient. And so these are often the types of patients that you might see in hospital, very unwell, and maybe even in the intensive care unit and needing support from machines and special medicines to stay alive.
Do you find it easy to diagnose sepsis?
I could probably talk to that after many years on the floor, as well as doing procedural. And I'll use the example of somebody with appendicitis, which is a very common condition, but you can be beside them, check them in to go into theatre, everything's quite stable, and turn around, all of a sudden they've collapsed, almost without warning. And one of the problems, of course, is that it can start off just like any flu-like illness. Headache, a bit of a fever, aches and pains. So the early stages of sepsis are traditionally difficult to diagnose without special tests.
Interesting.
I think one of the challenges for us in modern medicine, and particularly modern emergency departments, is that it's spotting that one person with fever or a bit of an infection or not quite right.
Yeah.
Who's going to go on to develop sepsis and who's actually just got a bit of the flu and needs some Panadol and some rest at home. It can be very challenging for clinicians to make that difference.
Absolutely.
And that was my third question. It was going to be noting that 10,000 people a year die from sepsis, which, as you pointed out, is more than cancer and car accidents. What are the challenges doctors and nurses have in diagnosing and when starting to treat a patient with sepsis? But you've already started discussing it.
Yeah, the approach, especially in the last sort of decade, has been doing really risk assessments on people who come in to the emergency department, because there are a lot of patients coming through that door have a fever.
Yeah.
And of course the trick is it viral? Is it bacterial? Is it something else? But now they do risk assessments, and from those risk assessments, either high risk, medium risk or low risk, gives some guidance as to whether they intervene and call this possible sepsis.
And is that vital signs and early warning scores, etc., part of it?
I like to think of it as somebody walking in the emergency department and it's time 0, and of course they get the nursing triage, take history, they take some vital signs, and they may move on to just doing some point of care testing. And as they gain more information, that builds up a picture of suspicion of sepsis or not.
Right. So
Some jurisdictions, Angela, do use sepsis pathways
Yes.
as a way of trying to assist clinicians in recognising sepsis. And certainly the literature would suggest that those sepsis pathways have been very successful in improving the time for patients to be recognised and treated appropriately for sepsis. But I think one of the great challenges for clinicians is that there is no biomarker, there's no blood test, there's no single thing that we can do at the moment which will tell us that someone has sepsis.
So what are some of the technologies on the horizon that could alleviate that?
Well, I think there are 2 main things, and then a third that follows from that. And the technology, everyone hears of AI, it's sort of on the news every day. I'm not sure if people fully understand the implications of AI when it comes to diagnosis like sepsis. So AI, it pulls the information and gathers further information from history examination, blood tests, x-rays, radiology, and it can actually predict before somebody will become very ill from sepsis. That's, to me, the first. And the second is, one of the problems is we have no rapid testing. We still have sort of 30-year-old technology that's mostly used, which takes time to identify these pathogens or bugs that get into the bloodstream. And so they're, to me, the main 2. And then followed up by very close, what we call antimicrobial stewardship, which is making sure that the correct information goes to a team who provides the correct treatment, and that's just as important. No point in doing any tests unless you follow them up.
And that's antibiotic therapy.
Yeah, and antibiotic therapy, there's antibiotic therapy and antibiotic therapy. I mean, Paul being an intensivist, by the time they actually reach him, they're usually being given multiple antibiotics in the emergency department whilst awaiting definitive identification of bugs. The aim of this game is as early as possible to give targeted antibiotics as opposed to what we call shotgun multiple antibiotics for a number of reasons, but probably the number one, side effects from multiple antibiotics, but also developing resistance. The bugs will develop resistance and we end up with superbugs.
One of the tensions, Ange, is that you want to get the antibiotics in quick.
Yeah.
And we could all, but also that you also want to take your blood cultures. The blood cultures are the foundation, generally speaking, of our diagnosis of the infection. And what we know is if we give antibiotics first, the accuracy of the blood cultures reduces significantly. So there's a tension there about wanting to get the antibiotics quick, but also wanting to draw blood for blood cultures. And one of the big problems is that, unfortunately, blood cultures are only positive about 50% of the time. So you can have someone incredibly unwell in the intensive care unit, for example, but still you're running a bit blind. You don't know exactly, you think you might know what you're dealing with, but unfortunately the blood cultures don't always give us the answer that we require.
And it takes a while, right?
Absolutely, it can take up to three days.
And as a person who used to take blood cultures, sometimes the sample's contaminated. There's a bunch of things. Some patients, you can't get that much blood out of them.
Exactly.
Without the proper approach to antibiotic therapies, you get superbugs. Is that correct? Tell me more about superbugs.
Well, superbugs, Paul, I like to use the analogy of Superman. Right, so you imagine all of these bugs there with their little Superman outfits on, and it takes a lot to kill them. And the only thing that impacts on them is some kryptonite, of course. And we're actually running out of kryptonite, and that's the problem. So these superbugs, more and more are developing, The research and development required to design a new antibiotic family is enormous expense, and the science has been limited, and so the potential in the future is getting back to the 1940s where we had penicillin, and if penicillin didn't work, then nothing worked. So it is a very serious problem, recognised globally, of course, but not recognised by community.
When we see someone with sepsis, we have to make a decision, often based upon the history and coexisting diseases and what we might have found on our initial examination, but we choose what we call empiric antibiotics. Mm-hmm. The problem with that is that the empiric antibiotics don't always cover resistant organisms.
No.
And so you can be treating the patient, but unfortunately it's not going to be effective. So being able to quickly diagnose whether the patient is infected with an organism that has resistance to antibiotics is really important, so that we can tailor the antibiotics to exactly what they need. And as David's indicated, that might mean bringing out the big guns and antibiotics that we wouldn't like to use indiscriminately, but to use them when they're really indicated for serious resistant infection.
Okay, so you've pointed to AI helping to predict that someone's heading towards sepsis, but what technologies are there now to help pinpoint what the pathogen is? Yeah,
I'm happy to talk to that. There are companies like Microbio that have been searching for what we call the Holy Grail, which is qPCR, quantitative PCR, which is a test direct on whole blood into the laboratory to detect pathogens that are in the bloodstream. In other words, results within 3 to 4 hours as compared to 2 to 3 to 4 days. And the earlier that you identify the pathogen, then the more prescriptive, more direct or more targeted. Again, one of Paul's saying as an intensivist that stuck with me, David, just give me the name of the bug and I can manage it from there, thank you. And so if he's got an unwell patient that could live or die in intensive care, and he's there waiting 1 day, 2 days, tapping the fingers, well, to give a clinician that clinical intelligence within a few hours is an enormous step forward in managing sepsis.
I think also knowing whether that bug is resistant to antibiotics is really important. And I know David might want to expand upon that, but I also think as a clinician, when you're going out and speaking with patients or with families, it must be really frustrating to know that your loved one's really sick and that they've got all this modern healthcare around them, but we can't actually tell them what the germ is. And you know, we're giving the patient lots of antibiotics, but in real terms, we don't have an answer for what's actually causing the infection. And so I think with the technology that David's talking about, I think it will really change the way we approach infection, but also I think it will give patients and our consumers a lot more satisfaction that we're on top of the infection and we can target it with the correct antibiotics.
Absolutely. With the Microbio, it's InfectID BSI, and it does cover 95%, the top 95% of pathogens that are sepsis causing. And so in most instances, if there is a pathogen in the bloodstream, then it will pick it up.
I mean, the use case for that apart from the emotional use case, I can imagine the cost use case for that, for the hospital system, must be massive too.
Well, it's one, cost, of course, is the health system is the biggest budget user across our community, and so we have to be cautious with cost. But when you consider the cost of testing versus the potential of saving lives,
For sure.
we often forget. We hear of the deaths, 10,000 deaths, but do we hear of the morbidity of that? And that's the thing. I think community awareness on sepsis, World Sepsis Day is important. The loss of limbs, the brain injuries, cardiac failure, ongoing, and like car accidents, we hear of death rates, but what about all the people who have serious long-term injury? And that happens with sepsis as well. That can be quantified, and certainly Microbio is in the process of actually having that quantified in some trials, and because administrators and politicians and budget holders, if you can prove that a patient has there's less death rate, less morbidity, and less days in hospital with precious hospital beds, intensive care beds, then it's a benefit not only to patients but to the community.
For sure, absolutely.
There's definitely local data here in Queensland that if you improve sepsis management, you reduce the length of stay of patients in hospital and you reduce the need for intensive care.
Yeah.
And I think with these rapid diagnostic tests like InfectID BSI, I think that we can reduce deaths from sepsis, reduce the morbidity from sepsis, but also get people out of hospital faster.
Yes, yes.
Brilliant. David, what's the World Health Organisation guidelines for potential sepsis diagnosis, etc., going forward?
Yeah, look, it's interesting you say that. It's one of any of our presentations that we use for InfectID BSI, we actually quote the World Health Organisation, who have 7 key criteria that they believe is warranted or needed globally to help the problem of rapid diagnosis of sepsis, and InfectID BSI tick every one of those boxes.
So David, how is it that we're only just now getting to this sort of technology related to diagnosing sepsis?
Well, it's a really good question, and there are a lot who have tried and failed before us. And in fact, if you go in the literature, sort of the early 2000s, where they were starting to use PCR and others. In fact, one company called Septifast by Roche, it did a similar type approach, but there's fundamental components of it that varies to what we have today. So there are, just in this last 2 to 3 years, Accelerate, T2 and others that have been trying to do this simply haven't come up with this. Professor Flavia Huygens has the USA patent in this, and I can't go through the exact reasons and that, but the technique that's being used for this product is that step ahead of others who have been trying.
I think you raised an interesting point, Ange, in that I remember when we first got troponin. Now, troponin is a biomarker for heart damage. So if you're having a heart attack, for example, you'll have a high troponin. And it was originally used as a sort of risk stratification tool in terms of how high your troponin was and therefore your risk of further infarction. And now it's really a diagnostic tool. You'll come into ED, you might have had some chest pain, and the doctors and nurses will do an ECG and they'll generally draw some blood for a troponin. And you know, if your ECG is all right and your troponin is negative, you'll generally be sent home.
Yeah.
So maybe one day in the future, you know, you'll have someone who's been a bit unwell, maybe a fever, and we'll be able to run a rapid test to say, actually, there's no large copies of bacterial DNA in your blood, you're safe to go home. Now that's a long way away, but I think that the way we use tests evolve over time, and it makes it safer for patients, and ultimately if a patient doesn't need to be in hospital, it's safer for them to go home. When we choose empiric antibiotics, you know, we might be right 80% of the time. So 1 in 5 people out there who come into hospital with sepsis may not be on the right antibiotics.
Yeah.
And so I think with a product like InfectID BSI, your number needed to screen in terms of patients who are on that sepsis journey. I can't imagine it would be any more than 8 or 9 people that you're going to need to screen to save a life.
Yeah, yeah.
And I mean, yeah, that's the guts of it. That's potent. Yeah.
And then, as you said, David, that's just the tip of the iceberg in terms of sickness, time in hospital, and then recovery time. And some people, as you said, are left with permanent damage from sepsis. So I think the impact of rapid diagnostics using PCR will be profound.
Okay, so in honour of World Sepsis Day on September the 13th, what advice would you have to ordinary lay people who are not healthcare professionals? to monitor or look out for signs for sepsis?
I think there are lots of websites. For example, there's a Queensland Government website now through the Queensland Sepsis Program, and there's lots of other information out there about sepsis. And so I think people do need to be sepsis aware. And then when they recognise some of those danger signs in themselves or a loved one, that they get to hospital or to their GP, depending on the situation. But also use the words, I'm concerned I might have sepsis. Because it's using those words often that will trigger the appropriate response.
Spot on. I was coming back to the Ryan's rule side. Children, mothers know their children. Fathers should, but mothers in general, know their children. And I've always said to the medical students and that, if a mother says my child is not right and I'm not leaving without, so you take notice,
yes,
right?
fine.
Because 95% of the time they're right.
Yep, my nursing knowledge says the same.
Yeah, exactly. And whilst we don't want to have the emergency departments full of people paranoid their child has a little sore throat and a bit of a fever, I'd prefer to see that than the other way of them going home and not returning because they've been told they've got the flu.
So, and this question's in line with that. What's your vision for the future on how we recognise and treat sepsis? Whichever one of you wants to start.
I think for me, as we move forward with AI technologies, I think there will still be a role for doctors and nurses in the loop. But I think that it would be great to have a predictive AI system that predicts sepsis.
Yes.
And can issue an alert, and then the doctors and nurses can review that patient, and if indicated, think about something like InfectID BSI, because that means that the patient's rapidly identified, the organism is then rapidly identified, and the patient can receive timely antibiotics. And I think that will make a significant difference to the outcomes for our patients.
Agreed.
Absolutely, and a big difference to the community, of course, with less destruction, less bewilderment, less pain. I mean, I hate to go through it.
With time, I certainly started my career without access to ultrasound, CT scan, MRIs, etc. And trying to treat a patient with sepsis is a bit like going back in time without the tools. And it's quite remarkable, 30 plus or more years that we've had this same sort of technique where every other element of science has gone like this. InfectID BSI, it's a laboratory-based test and it's quick. But part of the parallel research and development is ultimately we would love to see that developed into point-of-care testing. In other words, technology sitting in the emergency department, sitting in the ICU, or even the ward. So, and that's part of the future.
And I guess that could also be out in the field too.
Absolutely.
Point-of-care testing.
Yes. In fact, the Professor Flavia Huygens, who developed InfectID BSI, has done all the biowarfare and biological agents with both the US and Australian Defence Force precisely for that reason.
I think there are a lot of places in Australia that don't have access 24 hours a day to an advanced laboratory.
Yes.
And so I think point-of-care testing could be incredibly helpful for our community that live in rural and remote areas.
Yeah. And also think of the third world. And as we're developing, these really high-powered prescriptive therapies with immunotherapy and precision medicine, most deaths, of course, occur in the third world where they have no access. And I can say, Professor Huygens, one of her dreams is to see the technology being able to be used in the third world.
And I understand a large proportion of sepsis in the third world, or perhaps everywhere, is children. Yeah, that makes it all the more reason.
There's probably one other advance, and that when we take blood for blood cultures, and you touched on this, it's a large blood volume, and so there is some restriction, and I'm talking about neonates. Neonates die very quickly from sepsis. It's a common condition in neonates, and whereas this technology can do the testing on 0.5 mils of blood, which has a part to play in neonates or cancer patients that are difficult to take blood from. And so blood volume is another important factor.
Children with sepsis is probably one of the most scariest conditions that you can look after as an intensivist, and a lot of these kids unfortunately can die very, very quickly, within hours. And so I think this rapid diagnostic technology can make a big difference in those cases, because the kids can just deteriorate in front of your eyes, and you're really wanting the answer as to what is going on, and the traditional approach with blood cultures just doesn't give it to you.
No, it doesn't cut it.